All right, this Unit 2 does cover quite a bit of information. However, much of it is review. We'll be going over therapeutic relationships, the assessment of the psychiatric patient, the therapeutic environment, specifically looking at the hospital environment, and touching on rights, ethics, and legal issues. Therapeutic communication. A good portion of this at the beginning here is going to be review. I want you to review on your own in Chapter 10, definition of communication, variables that influence communication, and modes of communication. And I want to make sure that you know the nonverbal types of communication. The next section is the facilitative communication, superficial versus intimacy types of communication, and facilitating communication. Facilitating communication, I want you to review the facilitating the intimacy components, and then I want to take a look at more specifically techniques of therapeutic communication. And some people will also call those facilitative communication skills. The skills, I have all of the skills that your book has listed, but the ones that I have starred are the ones that I want you to pay special attention to, and we will be using, or you as a beginning student will be using most frequently. First of all is empathizing, and I believe that will be a review for you guys, so I'm going to have you look at that on your own. Active listening as well should definitely be a review for you students. Read in your book and then try to recall what you've also learned in 160 and 260 about active listening, all the components that are built into that, which include, body language, verbal communication, as well as verbal communication. So review that. Using silence is also a skill that should be a review for you all. But that really is important to let the person have time to think and to gather their thoughts, to reflect on maybe a question that you asked, or to reflect and put things together in their head before they answer. And that also just communicates to them that you are okay with them, and you are okay with them being quiet and silent, and that you are accepting of them even when they are quiet, and that the conversation doesn't have to be constantly filled with verbals. Reflecting, another skill, which again, I want you to read all of these, but I'm just kind of highlighting some of the important things. Reflecting is repeating either a verbal or a nonverbal message for the client's benefit. You may be looking at content or feeling. It might be that a patient, when you walk into a patient's room, they are looking very sad or very troubled, and some reflecting may be commenting on their nonverbal message, which is, you don't look very happy today, or you look, very sad today, and then letting them reflect on that. Imparting information is basically giving facts to the patient that they may need, and that also involves a lot of patient education. Clarifying is when a patient is saying something to them, and we want to make sure that we understand the client's statement. So we may ask a question in order to make the statement clearer for ourselves. Okay, and it may that one example would be if we ask for an example. If they said, I really hate when my parent does this, and you could ask, in order to clarify that or to gather a little bit more information, can you give me an example of what your parent does that upsets you? That would be one example. There are other examples. Paraphrasing is basically restating what the person has said. Again, it helps if they have talked about couple 2, 3, 4 paragraphs, and you are trying to get the whole kind of message pared down to try to understand what they have said. So restating what the person has said and checking to see if that was correct. And questioning is the last one on there. Open-ended, and I'm sure that you know this, again, a review, but the difference between open versus close-ended questions. And I really want to make sure that you know that for the most part, when we are trying to encourage the patient to express their feelings, we want to ask open-ended questions. There may be times, though, when close-ended questions are appropriate. For example, when we are doing an assessment and we know yes or no question, we want a yes or no answer. Another example might be when a patient is extremely anxious, when they may be in a severe or panic mode of anxiety, and we need to ask specific questions to gather information or to find something out or to direct them to a different area, etc. It would be very difficult for a person who is very, very anxious to answer an open-ended question. Culturally competent communication strategies. I'm going to have you all review that on your own from your book and take notes on that. Your book also goes into how the DSM-4 looks at different cultural communities, and I want you to review that as well. The next area that we have is therapeutic relationships, which is chapter 29. And I realize that we are jumping from chapter 10 all the way to chapter 29. And I've decided to do that because this is only a 2-hour course. There are different things that I want to make sure we get to and focus on, but I think that looking at these therapeutic relationships and some of the interventions with these therapeutic relationships will be important for us to know before we start learning about specific psychiatric disorders and before we get into that, because many of the nursing interventions that we will be doing for some of these psychiatric diagnoses will involve aspects of the therapeutic relationship. So I wanted to make sure that we review the therapeutic relations prior to getting into the disorders and the diagnoses. So this is in chapter 29. Basic definition, you can read in your book, of a therapeutic relationship is basically interpersonal interaction between the nurse and the client. And one of the big things with the therapeutic relationship is that it is the nurse focuses on the client's needs. Okay, so we can say that it is very much client-centered or patient-centered. Should not be nurse-centered. And the therapeutic relationships are the cornerstone of nursing. This book says psychiatric nursing, but I would go one step further and to say that therapeutic relationships are the cornerstone of any type of nursing that we do, that we have to build that alliance and that trust and that relationship with the patient before we can hope to be effective in our nursing interventions and in the nursing process. Okay, there is a handout on Blackboard about regarding social relationship versus a therapeutic relationship. What I have found with this new edition of your book is that it does a very good job in distinguishing between therapeutic and a social relationship. And actually in chapter 29 there is a table that talks about that gives a very, makes it very clear, and it is on page 777. The therapeutic relationship is an interpersonal model, and that was started by the nurse theorist Hildegard Peplau, and there's a picture of her, but she is a nurse theorist that based a lot of her theory from different psychologists from her time. Sullivan, she also used the learning theory, interpersonal theory. So this is her own theory, though, which looks specifically at the therapeutic relationship, but an interpersonal model. And it does provide a framework for us to look and to plan a therapeutic relationship with our patients to help the patient. Okay, so it is very patient-centered. The emphasis here is on the nurse helping the patient to observe their own behavior, describe and analyze their behavior. Also, things that are involved in the therapeutic relationship is making connections between behavior and patterns, and looking at patterns and then analyzing that. It may also be testing new behavior. If a person is testing out a new coping mechanism or testing out different communication skills, that is can be part of the therapeutic relationship. Okay, those are just some examples. The therapeutic use of the self. That is a phrase that Hildegard Peplau uses quite a bit in her interpersonal model. And basically what she is saying is that we are using ourselves to establish this relationship. We are using ourselves, ourselves as a nurse, but our whole personality to help the client grow, change, and heal. So we are using ourselves as a tool. And that is the therapeutic use of the self. The one-to-one relationship that is part of this interpersonal model, but also the therapeutic relationship, is mutually defined, collaborative, and goal-oriented. Those are the three main things that I really want you to know. But I also want you to be able to, explain that, know what those are. Therapeutic alliance, we can also look at that as trust that is built. Okay, and the building block for any therapeutic relationship is trust. It's a very fundamental process that has to occur before we can move into another stage and move into helping the patient make a change. Without trust, or without this therapeutic alliance, it's very, very difficult for the client to accept any help. If you do not trust somebody, why would you tell them, different things that might be happening in your life, very personal, very intimate things that are going on in your life? So we need to have that trust. And it's difficult for us to help clients if there is not that trust built. Cultural context, basically, again, kind of a review, but we have to realize that in any relationship that there is, the culture does play an influence on the client's expectations and their behavior, and that we should be constantly evaluating that influence of culture and adapting to that and collaborating with that culture. Okay, characteristics of a therapeutic relationship. I want you to look at, your book does a good job with looking through these. I want you to look through these characteristics, take notes on these characteristics, and I'm just going to highlight a few things here. Again, I already mentioned the table that was in your book that looked at that this is a professional therapeutic relationship and not a social relationship, and there are definite boundaries in a therapeutic relationship. Sometimes, if we do not keep these boundaries, such as keeping a professional relationship, sometimes that starts to blur the boundaries for the patient, and then some non-therapeutic dynamics can start to develop, and then we start to become ineffective with our clients or with our patients. And we don't want that to happen, so it's very important to keep those boundaries. I talked about, or briefly said, mutually defined. And if you read more about that, we know that that means two people are going to be involved here, and that it is defined by two persons. We also can look at it as that's actually setting up a contract with another person, and both parties of that contract have to sign off, if you will, but accept the conditions and agree to what is ever in that contract. Mutually defined is also that it has to be voluntary from both sides. If you force a person to have a one-to-one relationship with you, there probably will, or it will take a very, very, very long time for trust to be developed, if it will be developed at all. But it's very important that it's voluntary. When I start talking about the orientation phase of the therapeutic relationship, we'll talk more about this contract with the patient. It is collaborative. Both parties have to work together. Both have responsibilities. The nurse has a specific role, but the patient has a specific role also. It's not going to be the nurse doing all the work. Goal-directed, open, negotiated, committed. I'm going to let you guys read about those and take notes on that. The next slide is phenomena that occurs in a one-to-one relationship. First of all, we have resistance. And resistance is any type of behavior that blocks the process of the relationship. Sometimes it is seen as a struggle against the nurse, possibly specifically, but really what is going on is that resistance or struggle is against the anxiety that the person is feeling inside them. And that anxiety is felt when change is either starting to occur or the person is starting to think about and starting that change. That can create anxiety, moving from, even though it might have been a dysfunctional behavior before or dysfunctional thoughts before, many times change from an old way to a new way creates anxiety. And it may not be that anxiety is necessarily bad, but many times people do not want to feel anxiety, and sometimes people will go to any lengths to avoid feeling that anxiety, even though that they know that change might be good for them, or they logically can understand that. Acting out is another type of behavior that might occur in a one-to-one relationship. Acting out actually is a form of resistance that we just said, but acting out, again, because of some type of inner conflict that might be going on, the client is not able, or they choose not to verbalize feelings that are going on inside of themselves. Instead, they start to act out that behavior in an inappropriate way. The one-to-one relationship, if used appropriately, can help the patient understand this acting out behavior and hopefully give them feedback so that they can change that acting out behavior. An acting out behavior, can be, definitely on a continuum from minor to very extreme, but it might be, aggressive communication towards the nurse. It might be slamming doors. If we go to the very extreme, it's possible that there could be some, physical acting out, breaking something. It might be on kind of lower down on the extreme, where it might be missing appointments or falling asleep, during a one-to-one, along those lines. Okay, the next thing we want to talk about is transference and countertransference. As we are talking about this, I want you to kind of think about situations that have happened in your own life, and it could be a work situation if you've worked in the medical area before, or it might be situations that you have have seen happen with other people or personally. First of all, transference. Transference can either be a positive transference or negative transference. So just keep that in mind as we discuss this. But transference is a process that a person unconsciously, and this is basically taken from your book, unconsciously and inappropriate displaces or transfers. When we say displace, the same, we're just talking about transferring. They transfer onto people in their current life those behaviors or emotional reactions that started in relationships from childhood or with past significant others. All right? So that is transference, process where they inappropriately transfer, and it's not conscious, but transfer onto people that they are currently dealing with those behaviors or emotional reactions that started or originated back in past relationships, usually from childhood. Transference can occur in all relationships or any relationships. Many times, though, it occurs in relationships or it is accelerated and occurs more often in relationships towards persons that are in authority. Therefore, a doctor, a nurse, social worker can all be potential objects of transference. Okay, so as a nurse, and while we are practicing in this field, we have a greater chance, if you will, of people transferring, past feelings and behavior onto us, and we have to be aware of that as we begin to practice and as we are practicing. Okay, so when you start your clinical and for next semester, or as you are working in your healthcare places now, I want you to be kind of thinking about that. as I said, it can be positive or negative. One example of transference might be of a person who, from childhood never got along with their dad, and their dad was just maybe physically abused them, and they have a lot of negative feelings towards them, and now there is a doctor that they're seeing who definitely reminds them of their dad, and so there might be a lot of angry feelings towards that doctor, a lot of transference. Countertransference is similar, but what is going on here is that the nurse now transfers his or her feelings related to people in the past towards a patient. All right? So again, something to think about as we are practicing. If we are starting to have different feelings, or if somebody tells us about some types of behavior that we might be demonstrating, we need to really listen to that and reflect on it. But again, the nurse transferring feelings related to people in her past onto her patients. Frequently, a patient's transference evokes in the nurse a countertransference to that patient. For example, a nurse or a patient might transfer feelings of dependency onto the nurse, and the nurse feels extremely important when she is depended on, and depended on exclusively. And if this isn't recognized, or if the nurse isn't able to know where this has come from in the past and examine that, she may encourage that patient to transfer more dependency on her or become more dependent, and she may not be aware of that, and actually may not be helping the patient, or not helping the patient in the most effective way. Nurses can have very strong feelings or reactions to patients. They can be positive or negative feelings, as I said. Many times, if a nurse over-identifies with the patient, it may be more difficult for them to understand the patient problem. What the patient is going through, what's going on with the patient. One example might be a nurse who has an alcoholic father, and now she is working with, she may feel very disinterested, cold, or disgusted when working with an alcoholic patient. Okay, again, these feelings, this countertransference that she is having, is preventing her from understanding the real patient problem, and it's preventing her from having really the therapeutic relationship be patient-centered. And so she is not being effective because of this. So think about that. During class, I usually take a little bit of time for people to give examples of maybe where they have experienced either transference or countertransference. So I want you to think, pause here and think a little bit about that. Other phenomena that occurs in a one-to-one could be critical distance. I want you to read that in your book. Self-disclosure as well. Gift giving. As a student, we don't necessarily see that all that often. However, as when we develop relationships with our clients, and sometimes they are long-term relationships, can be an issue. But in any situation, gift giving from the patient to the nurse needs to be assessed and evaluated to see if it is appropriate. In the orientation phase, which we'll talk about in a little bit, in general, it's not good to accept gifts at this beginning phase of a relationship, and it really needs to be evaluated. Why is the patient wanting to give me a gift at this early phase? So whatever phase, very important to explore feelings regarding that gift. At the termination phase of a relationship, that is more of a common time where a patient would give their therapist, their counselor, their nurse a gift. And many times that is appropriate, but again, we need to be constantly assessing it and seeing if it is appropriate. And the size of the gift, the meaning of the gift behind it. Touch is another phenomena. And the basic general rule is it's best to avoid any kind of touch, especially in the orientation phase. But again, much like gift giving, it needs to be evaluated. Depending on your patient, sometimes even reaching your hand out at the beginning phase and shaking their hands, depending on what symptoms your patient is having and what is actually going on, could create anxiety or could cause possibly problems with developing trust or scare the patient, that sort of thing. All right. And that would be somebody who's, when we'll talk about later on, but somebody who would be more symptomatic. But again, basically, until trust is developed, best to avoid touch. Now, even after trust is developed, in general, okay, it's best to avoid trust. Now, sometimes there might be a situation where touching a person on the knee or on the shoulder might be appropriate. Okay, but again, it's just best to avoid that. And I'll also let you read on your own about culture, value, and beliefs. The nursing process and phases of the therapeutic relationship. This is when we're going to be looking at the 3 different phases and how we go through that relationship or those phases. I have the orientation phase as the first phase. There's also a pre-orientation phase and a pre-interaction phase where we're collecting data and reading the chart, exploring our own feelings before we even talk to the patient, reflecting on anything that might be starting to develop in us before we even make contact with the patient. The orientation phase or the beginning phase. I'll just pause right here. I didn't mention at the very beginning of the lecture, but I hope you guys are not only looking at this PowerPoint that I have, but this PowerPoint basically is just kind of taking you through the lecture outline. But so the lecture outline is much more detailed than what I have up here on the slides. Anyway, the orientation phase. The tasks that need to be accomplished here in the orientation phase are a personal contact with the patient and trust. Let's look at the contact first. We need to establish contact with our patient and define the boundaries with the patient. Your book, other literature, many times calls this setting up a verbal contract with the patient. And this is where we negotiate the therapeutic relationship. We make it a mutual process that both parties agree to this therapeutic relationship. And this is where we introduce ourselves. We tell the client what our role as the nurse is going to be, what the client's role is. We speak about confidentiality, that anything that's going to be talked about during this meeting or during our relationship will be confidential. And the only person I will be sharing this information with will be people on the treatment team. Again, letting the patient know who, as I said before, introducing yourself. I am a nurse here. I work full time. And letting them know who and what your role is. Part of that role is, just setting what's going to be happening. Every day that I'm here or that I'm working, I'll let you know that I'm here at the beginning of the shift, and then what I'd like to do is set up a time with you each day to meet with you for about 20 minutes just to talk about how things are going while you're here on the unit. That would be an example of like an inpatient unit. Now, of course, those scripts are different depending on where you're working. And then the client's role, at this point, you are also, kind of asking the questions of the patients. Is this, would this be something you'd want to do, to sit down and talk about how your treatment is going and that sort of thing, and possibly set some goals towards things that you want to work on. And we, always want to make sure that we give the patient opportunity to ask questions. All right, so that is the initial establishing contact with the patient, defining those boundaries, setting up that verbal contract. Okay, and all those things that we are doing in that beginning contact with the patient or that verbal contract is setting groundwork for developing trust. Okay, we are taking the time to let the patient know who we are, what we'll be doing, what they can expect from us, what we expect from them, talking about confidentiality. All of those things are laying the groundwork for trust. Without that important verbal contract, it is very difficult for the patient to trust us. It would be almost impossible without that trust to move into the working phase. Okay, that being said, I don't know how many times that I have had nurses and physicians come in and talk to me if I've been a patient. Usually it's been when I've been with my kids, either because of an emergency ER visit or a child in a hospital, where I have seen examples where nurses have come in and not done any of that verbal contract. Okay, and it's not, again, not just in the psychiatric nursing, but a nurse won't even make eye contact. She will not introduce who she is. You don't know who the heck she might be. She might be a phlebotomist. She might be X-ray technician, but not even introducing herself. So and just the fact of missing those two things can many times make a person suspicious or on guard or not want to engage with that healthcare provider. And that is actually is very sad when nurses fail to do that, because they are failing to put that building block in place that is going to be affecting the rest of their care with that patient, the rest of those interventions that she has. Okay, let's talk a little bit more about trust. Trust definitely develops over time, but there's, like I said, just with that verbal contract, there are things that we can be doing to start laying the groundwork for trust and setting an environment for that trusting relationship. Setting an environment for the trusting relationship, that should be a review for all of you guys. I think 160 and 260, and you guys know those, but some examples might be initiating, like I said, that verbal contract with the patient, active listening, responding to the patient, being consistent in what you do. If you say you are going to do something, make sure that you do it. Be honest, keep promises, non-judgmental, accepting behavior. We could go on and on, but all of those things that you've talked about in your other classes, also I want you to read about that in the book. And I'm sure you can, think of other things. One other thing that I will say here is that hopefully all nurses are doing this orientation phase, whether they work in the emergency room, whether they are working in a doctor's office, on a psychiatric unit. And you can start to be thinking about, are you doing that? If any of you guys are working as CNAs or in other aspects of the healthcare, are you doing this orientation phase with your patient? Are you establishing a verbal contract? And again, it can be relatively simple contract, but again, setting that groundwork for trust and setting boundaries, what they can expect of you. I think that's very, very important. And again, take some time here, pause, and times when you have seen nurses actually carry out this orientation phase, and when nurses have failed to do that. One thing that your book mentions, and I think is a good point to bring up, is that it used to be when, Hildegard Peplau was around and dealing with inpatient psychiatric patients, that many times those stays for patients were anywhere from, a couple weeks to a couple months to 6 months, and we could really see this nursing process and the phases of the therapeutic relationship really play out. And sometimes, we had the luxury of having the orientation phase last, 1 week, 2 weeks, even longer. And many times when we're doing outpatient treatment or doing counseling, that's how long the orientation phase may take. However, sometimes when we have patients that are actually in the hospital, and they're only in the hospital 2 or 3 days or shorter, that this orientation phase obviously is going to be accelerated to some degree. So just to keep that in mind, but that doesn't mean that this therapeutic relationship cannot take place just because you're only with the patient for 8 hours, or just because you're only with them for 2 or 3 days. The working phase is the next one. Remember, unless those tasks are accomplished in the orientation phase, we cannot move into the working phase. Okay? Or if we move into the working phase, because we're pushing it before trust is built, you may see more resistance from the patient, or you may see nursing interventions that are ineffective. Things that we're going to be doing here, we're going to be using our communication skills to help the client learn about himself, explore problems, and begin work on behavior changes and growth. Some of the tasks that we need to accomplish: maintain the relationship, and basically what we mean here is maintaining that trust. Exploring the goals that were possibly set and talked about in the orientation phase. Exploring those in the therapeutic contract and a therapeutic relationship. We might explore behavior, areas of the patient's life that are causing them problems, trying to identify behavior problems or difficulties. Analyzing behavior. What's going on? What's the source of that behavior? What was the origin of it? What kind of effect is that behavior having on the patient? What kind of effect is that behavior having on other people in the patient's lives? Helping the patient do a self-assessment, and which hopefully is going to lead to behavior change, but encouraging that self-reflection, self-assessment. The termination phase is the last phase of the therapeutic relationship, and just as it says, it's termination of the contract, but in a mutually satisfying way, where both parties are satisfied. Okay, at this point, I just want you to pause a little bit, and I want you to think of a time when you needed to terminate a relationship, or a relationship in your life was terminated. How would you feel if you did not have closure in that relationship? Okay, it might have been a death of a significant other in your life. It could have been a breakup of a relationship in your life. It could be the ending of a job and terminating relationships with different people at your workplace. But think of that. What if, and maybe some of those relationships that you actually had, you did not have closure. And if that's the case, I want you to think about some of the feelings that you had at that time. Or I want you to try to imagine if a relationship was terminated without closure. What kind of feelings might you have? When we talk about this in class, many times the experiences that students bring up are relatively similar as far as the feelings they have. Sometimes students will describe feeling very, very sad. Sometimes students will describe feeling very angry or frustrated or guilty. So there's a lot of different feelings that go on when there is a relationship that ends without closure. Two of the tasks that we need to get accomplished here in this termination phase is actually terminating the contract and then an explicit goodbye. And actually, on the hand up on this slide, I am missing an important part, but I do have it in your outline that we need to make sure that we are, first of all, evaluating the therapy contract and the therapy experience. That is one task that we need to do. Basically encouraging the patient to express feelings regarding the relationship, and the nurse gives a chance to give feedback to the patient. The nurse is able to kind of summarize whether it has been a couple days of counseling sessions or maybe it's been 6 months of counseling sessions, but it is able to summarize and kind of look at what goals may have been accomplished, what are areas in those goals that still need to be worked on, what things didn't we get to possibly in this relationship, and kind of summarizing and giving feedback, but also letting the patient talk about the relationship. Have they been satisfied with it? Has it been successful? What are they thinking about, no longer, coming to meet with the nurse? Another thing that we need to do is encourage transfer of dependency to a support person who's in the patient's immediate environment. The relationship now that you have with that patient is going to end, and there was a degree of dependency that patient had on you. Now we need to make sure that we encourage them to transfer that. And we will have to also evaluate and give suggestions. It may be that this patient needs to have a counselor outside of the hospital or go to a long-term, counseling relationship. We would want to encourage that and maybe even facilitate, some of that setup. It may be that they don't need to have counseling anymore, but it may be that they need to find somebody in their life that they can talk with and use coping mechanisms such as venting, talking, problem solving. Many times, I'll ask, is there somebody in your life that you can talk to about things, talk about feelings, and many times they are able to identify a spouse, a friend, a sister, that sort of thing. Sometimes, though, by asking that question, you'll be able to identify that, actually they don't have anybody, and maybe I need to explore with them who that person might be, and maybe that's going to tell me that maybe they need to have some kind of community support. But just because they're married, that does not mean that their spouse is a person who they go to talk about feelings and problems and as a coping mechanism. So we need to examine that with the client. Then we need to say an explicit goodbye. Because that explicit goodbye, telling the patient, it's been nice working with you, goodbye. You can wish them a good luck, in their life or whatever. But that really sets that boundary that this relationship is over and it's not going to continue. Okay, and that is the therapeutic relationship. We're going to pause. So in the history, first of all, chief complaint, which you guys know is recorded in the patient's words. And usually, I know you guys have covered this before, but usually one of the best ways to ask that chief complaint is, what's bringing you into the hospital today? There are variations on that, but something along those lines. We also want to ask the patient about present symptoms that they are experiencing and when the onset was. When did they start? The development of those signs and symptoms. Also want a history of previous hospitalization and mental health history. Usually if we ask, can you tell me over the last 5 years when you've been hospitalized or seen a specific counselor, that sort of thing, because many times within those last 5 years we can pull up old records which can help us very much. Family history. Any family members that have sought treatment in the past, have been hospitalized in the past. Sometimes patients are able to tell as well, one time my mom was hospitalized because she had a mental breakdown. Again, they don't have a diagnosis for us or can't tell us, anything really specific, but sometimes that a mental breakdown is at least a start with kind of that family history that we know that there's something going on, and then maybe we can use our collateral sources to explore that a little bit more. Personal history, the birth of the patient, if they have any information about the birth, the development, normal or abnormal development from, when they're a baby up to adulthood. Occupation, any problems during, work periods, interests they might have, marriage history, alcohol, drug, religious, spiritual. I want you to look at that a little bit more in your book, the personal history. And personality. What that is referring to the client's relationships that they have. Are they successful relationships? Are they difficult relationships? Moods, feelings that they might be having related to that. Okay, the next segment of the psychiatric exam is the mental status exam. We covered this a little bit before, but we know that the mental status exam is has a standardized process. Everybody should be doing it the same. But the purpose is to gather more objective data to use in the diagnosis, treatment, and looking for the etiology. First of all, we're looking at general behavior, appearance, and attitude. And I know from your previous classes, you guys have learned how to do this. There's a very good example in the book. But basically, we are describing the patient. Do they appear their stated age? Are they dressed appropriately? Is there anything out of the ordinary that you are noticing with this patient? Any mannerisms that seem to be out of the ordinary? For example, if a patient comes into the emergency room and it's wintertime and they're dressed in a summer dress with sandals on, or we could go on and on about how we could describe a person, but prominent tattoos, if they have a body odor, if they look disheveled, etc. Characteristics of speech. Here we are looking at form, not content, not exactly what the words are, but the form, the patterns that we're seeing. We can first look at speech. How loud is the speech? How soft is it? The flow, the speed, very fast or very slow. The quantity of it, is it logical? All of these things about a person's speech can help us discern if they're having difficulties with their thought process. On page 218 in your book, there are terms that describe characteristics of speech, and I do want you to know those. Mutism, circumstantiality, perseveration, flight of ideas, and blocking. Let me turn to page 218. And some of these you may not have been exposed to before, but mutism, should be a review. No verbal response. Circumstantiality. Many times a person gives a I think of it as a person going off in a big circle, that they give me, if I ask a question, they give a huge explanation to my question. They eventually might get to the point where they answer it, but it's very circumstantial. Sometimes they never get around to actually answering my question. Perseveration is a pattern of repeating the same words or movements. Also, many times we see perseverating on a specific thought, where a person, whenever I sit down and talk with them, are always bringing up some specific situation that bothered them. Even when I try to start a conversation on something else, they're always bringing it back to this idea that they're perseverating on. Flight of ideas is pretty straightforward from your book, but a person who is jumping from topic to topic, very fragmented. It is that flight of ideas. Many times it's difficult to follow what they are trying to say, and usually going relatively fast. Blocking is a pattern of sudden silence in a stream of conversation. Patient might be saying something that all of a sudden stops and might pause for 5 or 10 seconds, and then may or may not pick up where they started for. But usually what's going on is when they're answering a question, there's some other thought process that blocks their sentence, and it might be a delusion or it might be a hallucination that is blocking that. But blocking can be a symptom of something else that's going on in their with their thoughts. Okay. Emotional state. This is basically what is the patient's dominant mood. Are they feeling down in the dumps, nervous, etc. But the emotional state, usually the best way to ask this is, can you describe to me your mood today? And then hopefully they will be able to tell us in 1 or 2 words, and then if we need to, we can ask them other questions to help them describe it or elaborate their mood. Emotional state, or their mood, it's subjective from the patient, so we want to make sure that we are aware of that, and we just can't assume that a patient is in a good mood or a bad mood. Just because a patient is smiling does not necessarily mean that they are feeling happy. So we definitely have to ask every time we're doing an assessment, describe to me your mood, or how is your mood today. We know that with many of the symptoms of certain illnesses that a person can have incongruent mood and affect. So we need to assess for the mood first by asking that question. Signs and symptoms also that might go along with this mood: facial expression, motor behavior, tears, or sweating. We also want to document those. When we are assessing for affect, affect is basically what kind of emotion is showing on the face. And there are different ways we can describe that affect. We can describe it as a full affect, and a full affect would be, if you want to say, a normal affect. We don't use that term normal when we are documenting or describing, but a person, you or I, who would have a full range of emotions in our face. When there's a sad situation, we're able to show sadness. When there's a happy situation, able to show, happiness. A flat affect is the complete opposite. No emotion at all on the face. When a person is sad, there's no emotion. They might have a totally flat affect and it be the day of the funeral of a parent, but showing no affect or sadness. A blunted or restricted affect, that I don't believe is in your book, but oftentimes we'll see that being documented with patients, and that's basically in between a full and a flat affect. A patient, many times people who are very depressed have a restricted affect, that they can show a little bit of happiness, but it's almost a little bit strained. It's not the full range of somebody being happy. Okay. Inappropriate affect would be affect is inappropriate to a situation. For example, a person might there might be a very sad occasion that might be going on, or they might have just gotten arrested or whatever the case is, and they might be laughing and joking, almost as which is very inappropriate to the situation. I want you to know what a congruent mood versus an incongruent mood is. Does the mood and affect match to the situation? Next we have here is content of thought. This is a special preoccupation or experience that the patient might be having in their thoughts. Okay, the 5 that I have listed down here, I want you to know, and as you are looking at these, if it's not making sense, I want you to bring your questions to class, because we'll definitely be seeing, this mental status you'll be tested on that. But first of all, let's look at delusion. Your book does a good job of describing these in your book. And I do want you to know the different types of delusions that are listed in your book. Okay, first of all, what is a delusion? A delusion is a false fixed belief, meaning that it is not true. Whatever that idea is that it's not true. It might be, and also that it's fixed. And the fixed part means is that even though there's evidence that what I believe is not true, and even though there's overwhelming evidence that it could never happen or that it's not logical, I still believe it. You cannot talk me out of my belief. So that's a false fixed belief. One example might be a patient who believes that there's invisible gas being pumped into the room through the vents. All right. So even if I would sit down and say, it's impossible for invisible gas to be, pumped in here. Nobody would do that. It's impossible. I'm healthy and I've been in here now for 10 or 15 minutes. You've been in here now for 3 or 4 days and you are very healthy. All the things that I might do to try to convince him that it would be an impossible, occurrence. He's not going to believe it, but it still believes, and that's a false fixed belief. Your book, when it talks about delusions, gives some different types of delusions. Nihilistic delusions, self-deprecation, delusions of grandeur, somatic delusions. So I want you to know those different types of delusions. Hallucination is a false sensory impression with no external stimuli. Okay, and a hallucination can take part or occur with any of our senses. A hallucination can occur with, like I said, any of the 5 senses: hearing, seeing, smelling, tasting, or touching. And again, it's a false sensory impression, meaning that they are actually feeling it and sensing it, but there's no external stimuli that would be causing it. The best way to assess for hallucination is to actually come out and ask a person if they are having any, are they possibly hearing any voices or seeing anything, or are they having any uncomfortable sensations. And more times than not, the patients are able to actually tell you, yes, I'm hearing this voice over and over in my head, or not necessarily in the head, but they won't say that, but I'm hearing these voices, or at times I will see this. Unless the patient is very, paranoid or scared or that sort of thing. But at least we're able to document that they're, denying it. Sometimes patients will deny it, but there are other ways that we can see if a patient is hallucinating. For instance, if they might be talking to themselves, that might be an indication. If a patient is looking up, say, at the ceiling or cocking their head and appear to be listening to something, or if they are thought blocking, or are preoccupied, those are also some symptoms that a patient might be hallucinating. An illusion, now your book doesn't actually say talk about an illusion, but I want to make sure that we do talk about that, because sometimes patients will have illusions and we will get those confused. But an illusion is when there is actual stimuli coming into the patient, but they are misinterpreting it. Okay? So for example, a patient who is you come into the room and they're laying in their hospital bed, and they ask, what are, and let's say it's like 10 o'clock at night, the lights are starting to be shut down out in the hallway, and we dim the lights in the patient's room so they can fall asleep. But the patient, calls us in and says, I'm seeing those little rabbits over there in my corner. What are those? And as you investigate a little bit further, there's no rabbits in her room, but there are some shadows that are is a stimuli that's coming into her, and she's actually misinterpreting that as rabbits. Okay, so there is a difference between illusions and hallucinations, and I want you to know that difference. An obsession is an insistent thought from within, and it continues to persist even if the patient tries to get rid of it. Now, compulsion is obviously it's a behavior, but it's a repetitive act that's performed, and it's performed to try to get rid of that anxiety, okay, that the obsession is causing. Okay, and that's where we get that term, the obsessive compulsive disorder. The person has the obsession first, that persistent thought that they can't get rid of, and causes a lot of anxiety for the patient, and so they try to get rid of that anxiety by performing some type of behavior, usually ritualistic behavior, whether it's washing hands, touching the doorknob a certain amount of times, etc. Fantasies and daydreams are preoccupations that the patient may be having. Many times it's difficult to get these from the client, but again, it is a content of their thought. Okay, moving on with the mental status exam, then we have orientation, and I know that you guys know how to assess for orientation, but time, place, person, that would be oriented times 3. Many times you will see oriented times 4 in charts, and that is basically oriented to the situation. Do they know their self, their purpose here, what's going on? Memory is a patient's attention span, their ability to retain or recall past information. We can call recent memory information and remote. How can they have no recent memory recollection, but they can remember what happened in their childhood, or is it reversed? Okay, and it's very important to distinguish between that. Your book does a good job with talking about that. I also want you to make sure that you know what confabulation is. And that is in your book. Confabulation is basically a person who is not remembering things, but they invent memories to explain something. So things that they cannot recall, they make those up. Now, we don't necessarily call it, intentional lying, because they are using it more as a, coping mechanism to kind of save face in some situations, and sometimes it just causes too much anxiety if they can't remember it, so that it seems like they are making this up, and we call that confabulation. Many times we'll see that with people who have delirium, alcoholics that are starting to have dementia. Many times we'll see it with that. General intellectual level is the patient's ability to use factual information. Sometimes we will assess that by asking them, can you tell me the names of the last 4 presidents, or can you count backwards from 100 by 7, and see if they are, getting those right. Abstract thinking is the next one. Are they able to interpret, or, there's a difference between concrete thinking and abstract thinking. Concrete is very, literal, what is going on at the time, very, specific, but abstract thinking is looking at things, in a broader sense, conceptual thinking. But is a person able to interpret simple fables or proverbs? Many times we will ask them, do you know what it means, or tell me what it means when people say that people who live in glass houses should not throw stones, and we ask the patient to interpret that, and if they interpret that correctly, then they have good abstract thinking. Or what does it mean when it says that a rolling stone gathers no moss, and ask them to describe that, and it gives us a pretty good assessment of their abstract thinking. The next thing we have down here is insight evaluation. Is the patient able to tell us the significance of the present situation? If they are in the hospital in the emergency room, are they able to tell us, the exact reason why they're there? I'm coming in because I'm having these, specific symptoms. Or are they telling you, well, I'm not really sure why I'm here. I was sitting at home minding my own business, and all of a sudden the police grabbed me and brought me in here. I shouldn't be here in the hospital. There's nothing wrong with me, etc. That individual might not have insight into the situation. So we're asking them, can you tell me why you're in the hospital? Can you explain, why you might be having these symptoms? Okay. Along with that insight evaluation, many times people will make a look at the patient's judgment. Are they using good judgment, poor judgment? Are they making good decisions, that sort of thing? One way that many times we will look at judgment was we'll ask a patient, what would you do if you locked your keys in the car? And depending on what the patient says, we'll evaluate that. Some patients will say, well, I would call my wife and ask her to bring me my set of keys. Another patient might say, well, I would might give you a whole different story that would totally not make any sense. Okay. Another question that we might ask is, if you found a stamped letter on the street, what would you do with it? Most people would say, well, I'd try to either take it to the post office or put it in a mailbox. Again, if a person gave you a whole different type of scenario about what they would do, we can kind of take a look at what their judgment is. And then summary is the last thing. Usually a physician will fill this out, but they give a preliminary diagnosis. They talk about certain findings from the mental status exam. All right. I also have down here a mini mental status exam, and I don't want you guys to confuse the mental status exam with a mini mental status exam. They are two different things. The mental status exam is just what I talked about, and the mini mental status exam is actually a 30-point test that we give to patients, and then we report that score. It's a type of documentation. I'm going to bring those to your next class, just so everybody can have a copy of that and kind of look at that. Most other university hospitals that I have worked at, nurses were required, that was part of their admission assessment, is that the nurses would do these mini mental status on every single patient that came in. Genesis Hospital, we do not, for whatever reason, do not do that at all. I don't see it used very often at Genesis, but I think that it is a very good tool to get a good idea of what's going on. The other question I will remind you is that to make sure you know that the mental status exam is a snapshot of the person at that present time. I already talked about that once, but it's not, how they were doing yesterday or 2 weeks ago, but it's what's going on with them right now. Okay, to continue on with the psychiatric exam, we talked about the history and the mental status exam. Now let's look at the physical, neurological, and psychological assessment. The client signs and symptoms may be due to physical problems that might be occurring, biological or neurological problems that might be occurring. So we definitely cannot forget to do a good physical neuro and psych exam or assessment. For instance, the patient may be having a brain tumor that might be causing many of the symptoms that we're noticing. The patient might have Alzheimer's disease that might be causing certain symptoms. A urinary tract infection, as we know from many times individuals from nursing homes that have a urinary tract infection start to exhibit some cognitive symptoms. And we'll talk more about that when we talk about delirium and dementia. Thyroid problems, we've talked about that. So that's why it's very critical that we make sure that this is a complete assessment. Physiological assessment is taking a physical history and doing a physical exam. looking at any physical complaints the patient has, making sure we are taking a good medical history, what has happened in the past, and that also includes a good history of their medication therapy, and also looking at their general and current health. On page 221 in your book, there's a good example of the physiological assessment, and so I would like you to read that. Neurological assessment is just to make sure that we're taking a good neurohistory, looking at any type of brain dysfunction, head injuries, past head injuries, and if required or need to, is that making sure we're getting a CT or MRI or PET scan. Psychological assessment, these would include certain things such as intelligence tests, seeing where their IQ is, personality test. Many times personality test would be administered by psychologists or research assistants. Many times a psychiatrist will have psychologists that will be in their office, or other people that can perform those tests. Also looking for any type of mental retardation and cognitive functioning. I'm not going to go into all the different types of tests that might be performed in a psychological assessment, but your book does a good job of a lot of those exams, such as the Beck depression test, different surveys that might warrant a patient might have symptoms that might warrant taking different types of tests that will help with making an accurate diagnosis and seeking the best treatment. The next thing that I want to talk about is the psychiatric diagnostic practice according to the DSM-4. Again, last class we did talk about the DSM-4 and the basics of that. And to remember that it is a multi-axial assessment. We talked about the benefits with it being multi-axial. We also talked about there was an increased interclinician reliability when we use the DSM-4. So that from one physician to another physician to another physician, that they are making the same, hopefully making the same diagnosis, or it increases that capability. Okay, the axes. We have 5 different axes, and I want to go over those in a little bit more detail. Axis 1 is the patient's primary psychiatric clinical disorder. I know that I have in your lecture outline just saying clinical disorder. Don't mix that up with a medical diagnosis, but this is the clinical psychiatric disorder. So it could be schizophrenia, depression, bipolar affective disorder, post-traumatic stress disorder. Axis 2 is if a patient has a personality disorder or any type of mental retardation. Many times Axis 2 will be left blank, or it will simply state no Axis 2 diagnosis. A personality disorder, we will talk about that later on in the semester, but just because you are coming into the hospital with depression or another diagnosis does not automatically mean that you have a Axis 2 diagnosis. Axis 3 is a general medical condition, which is, and we want to make sure that we address this because many times people with medical conditions have symptoms that might, or have issues that might be causing psychiatric symptoms, or just helps us kind of better understand what's going on with the patient. So a general medical condition example might be congestive heart failure. It might be history of, history of, brain injury or traumatic brain injury in 1999, etc. Axis 4 is psychosocial environmental problems that might affect the diagnosis, treatment, or progress. This might be negative life events such as a divorce, a job, or job loss that is creating stress and problems in the person's life. It might be an environmental difficulty such as a patient living alone. Okay, sometimes that poses no problems, but then at other times, depending on the patient, that might be a significant problem for them if they don't have any support at home. Axis 5, global assessment functioning. And you can see up on the slide there that I have Axis 5 kind of highlighted there, the global assessment functioning. That is on a scale of 100 to 0, and I have down there that 100 being the most superior functioning and 0 where the patient can't take care of themselves at all or might be at a danger to hurting themselves. And the physician will rate the person's functioning along the scale. They're assessing for overall level of functioning, and hopefully when we know they're functioning, this will help us to plan for the best type of treatment, the best type of resources that is needed. I want you to review from your book the place of assessment in practice, and also the use of the DSM-4 in I'm sorry, just pause for a second here. Also the use of the DSM-4 with sorry about that, I kind of lost my place. But the DSM-4, the place it has in nursing, psychosocial assessment. I'm not going to review all of that. We're just focusing on the areas that I highlighted in our lecture outline. So that is going to be the end of this segment. The next slide that we have here is a therapeutic environment in a hospital-based care. Now, in chapter 12 in your book, page 246, prior to this, the therapeutic environment in the hospital-based care, the chapter talks quite a bit about all different types of care, community-based care, managed care, case management. Unfortunately, we are not going to be able to take the time to talk about all of these different types of care in class, but I want you to have a basic understanding of what community-based treatment is, managed care, and case management. So we're going to focus our time here on the hospital-based care. First thing we want to talk about is the therapeutic environment. If I would give you a definition from your book, it's a purposeful use of people, resources in the client environment to ensure safety, optimal functioning, increase in interpersonal skills, and an increased ability to be independent. So that is our technical definition. We'll talk more about this. We also many times hear the term therapeutic milieu. And therapeutic milieu, depending on who is using it, might have varying definitions. But in the broadest sense, it's a treatment environment philosophy. How people are looking at the whole environment that we are having the patient in, not just their physical environment, but the programming that is going on, the types of disciplines that are involved. So it's a very, very broad sense of the environment. If we were very specific, many people will use therapeutic milieu also to describe the physical environment. And so they might, one example of a therapeutic milieu that we can kind of look at is when we look at some of the birthing centers that are in our hospitals now. How would you describe the therapeutic milieu of that birthing center, the OB floor, if you will? Depending on the hospital, many times the new philosophy or the new therapeutic milieu of many of these units is that it is trying to be mimic a home environment, a very calm, nurturing, as much like home as possible, so that the mother, the baby, the family can have a very comfortable, decreased stress type of experience versus having bright lights, operating room table, tons of people in the room, fathers aren't allowed, significant others are not allowed in the room. Okay, so that has changed to be, nice, nurturing colors, calm colors, couches in the rooms, father, pull-out couches where the father or significant other can stay in the room, etc. The therapeutic environment, and so it's not just, as I said, it's not just the physical environment, but it's what kind of staff are there, who is allowed in the room, a whole type of philosophy. The same way with psychiatric inpatient hospital-based care is that we're not only looking at the physical environment, but also who we let on to the unit. Is the unit locked? Is it opened? What kind of groups are going to be going on in the day? Excuse me. I do want you to read in your book the unique role for nurses in a hospital-based environment. Other things, and I also want you to look at external factors for the therapeutic environment, which is in your book in box 12.3. They talk about a few of those: privacy, autonomy, safety, group well-being. How do they set up those external factors, and what do those mean? Therapeutic environment principles on page 248 in your book. I want you to read through those, be familiar with those, as well as what the rationale is. A few things that I will highlight down here. First of all, restrictiveness. Most hospital-based programs use this principle, and they use the principle of the least restrictive alternative as possible. However, of course, a hospital environment is going to be more restrictive than the community, but they also want the least restrictive. For example, the behavioral health units or psych units that are over at Genesis, they have two different units. They have one unit that is locked, and those are for more symptomatic patients, patients who are more unpredictable and who require more safety safety things that in place, such as a locked door, such as a smaller environment, less stimulation. But that is restrictive in that that door is locked. Now, what they also have is an open unit where the doors are not locked, and so they have the option of assessing a patient and deciding which patient needs to be in a more restrictive environment and which patient can be in the, putting them in the least restrictive environment that is necessary for that patient. Another principle that we have down here is orienting the client and the family, making sure that we inform the patient what to be expected here on the unit, and hopefully through this information, informing the patient and the family, we are going to also help engage them in the treatment process. And that kind of harkens back to our therapeutic relationship and some of those principles from the orientation phase. So kind of recall those as far as the orienting the client and the family. Safety and structural environment speaks to security, the way the environment is structured to make sure that it is secure and safe for the individual. One of the things, again, on the Genesis behavioral health units, some of the things that they have a mirror in the bathroom, but it's a non-breakable mirror. They have hinges on the bathroom door as well as on the hallway door to the patient's room that have hinges that can go either way, so that a patient cannot barricade them in the room. The hooks that they have in the bathroom are fall down if there is a certain amount of weight placed on them. So those are some examples. There's no locks on the no locks on the doors. There's no hospital beds actually in the bed. So those are some examples of actual safety structures that are put into place. Along with that safety and structural environment, some of the other things that the hospital, that part of that therapeutic milieu, will be to have policies about, say, seclusion and restraint. That, very specific, spelled out seclusion and restraint policies, which is part of that environment. Program structure. An example of that program structure for the therapeutic environment would be, say, on the open unit, because those people are not as symptomatic, they're not as acute, their thought processes are more stabilized than, say, the patients that are on the locked unit. Anyway, the program is structured differently. There are groups that are going on pretty much anywhere from 8:30 to 3:30 in the afternoon, various types of groups, and the patients are encouraged to go to those groups to start to learn about coping mechanisms, start to learn about how to deal with stress, problem solving. Some other things that are in that program structure are, but also kind of relates back to the structural environment as well, is people do not have phones in their rooms. Individuals do not have TVs in their rooms. And what this does is encouraging people to come out to the day room to eat their meals, to do some more socialization. That you're not just staying in your room watching TV all the time, or you're not just staying in your room talking on the phone the whole time. Okay, so there is a philosophy behind these things that are in the environment. And that contrasts to the locked unit, where their patients can eat their meals in the room if they so choose to do. Patients can stay in their room all day. There's no groups that are going on in the locked unit, because many of those people are very symptomatic, more acute. Their thought processes would not be helped at all if they were going into a group which is requiring them to think and do problem solving and that sort of thing. So again, very much a philosophy behind all these therapeutic environments. I will let you read about the others that I have listed down there. I do want you to pay attention, as I said before, to those strategies on page 248. Okay, the last couple of slides that we have here deals with rights, ethics, and advocacy. Although I have more on your lecture outline, I'm going to highlight the main areas that I want you to focus on. First of all, I have down here the ethical guidelines for the psychiatric mental health nursing practice. Where do we get those ethical guidelines? How do we know, where we should be going to answer some of the questions or help us to deal with some of these conflicts? First of all, there are two sources that I have down there. The scope and standards for psychiatric mental health nursing practice deals with ethical guidelines, helps us to make decisions regarding this. Standard 5 deals specifically with the psychiatric mental health nursing and reiterates what we have already talked about, that the foundation of psychiatric mental health nursing practice is a therapeutic relationship with the patient. It also focuses on, or highlights that the boundaries of this relationship need to be established to protect the patient. And that if we many times patients will try to breach these boundaries, and we need to redirect them back to the boundaries. And it gives guidelines on that, but that as nurses, we should not violate those boundaries of the therapeutic relationship. It also emphasizes that a professional relationship is confident, that we should act as advocates, be non-judgmental, be non-discriminatory. Talks about the need to report abuse, the need for informed consent process involved for the patient. The second area here to help with that provide ethical guidelines is our ANA Code of Ethics. You all should have reviewed various forms of these ethics in your fundamentals course, and we can always go online to find those to help us, or there are in our fundamental books, but also addresses ethical issues. Ethical dilemmas speaks to giving some major dilemmas that many times as nurses we deal with: the stigma of psychiatric disorders, controlling individual freedom, client privacy, and confidentiality. This area I would just like you to briefly read, briefly give an explanation of each one of those. The next slide I'm going to spend a little bit more time on, which is the legislation, commitment, and hospital issues. The first thing that we are going to be talking about is admission and commitment issues. Courts and legal rights play a very, very important role in how we practice psychiatric nursing. There is legislation in place to protect the patient's rights. This legislation varies from state to state. And as a nurse, and as a psychiatric nurse, you must be aware of your state's mental health statutes, code, or laws. So that's important, so that wherever you're practicing, you are aware of those. That is how many of the hospital's policies and procedures are based upon. They cannot violate those codes. For example, putting a patient in restraints cannot violate any of those state mental health laws or statutes. Specifically, when there are two different types of admission and commitment: voluntary admission and involuntary admission. Let's first look at voluntary admission. Voluntary admission is the right to demand and obtain release. What does that mean? That a patient can be voluntarily admitted, and what we do in the state of Iowa is that we have them sign a voluntary admission form. When they sign that voluntary admission form, that states in there that they have a right to demand and obtain release whenever that they want to. Usually, if they want to be discharged, many times we notify the physician, and the physician will ask them to fill out a against medical advice form, and we can ask them to do that. But they definitely, if they're a voluntary admission, can leave whenever that they want to. The second type of admission is an involuntary admission or involuntary commitment. And under there we have three different types: petition for commitment, emergency or 48-hour hold, and involuntary outpatient commitment. The first one, well, first of all, let me say that again, this involuntary commitment varies from state to state, so we have to abide by the state laws that we are practicing in. Let's look at petition for commitment first. Petition for commitment is when two people, it has to be filed by two people, but basically two people decide that, usually it's a family member or significant other, two people decide that this person needs help, but even though we've been asking this patient to go into the hospital, go to the doctor, they're not taking, family advice. So two people are worried enough that they go down to the courthouse and file commitment papers on that individual. Now and then the people, part of what they are filling out is saying why they believe this patient needs to be admitted, and what they are looking at with these petition papers is are they able to describe in there that the patient is a danger to themselves or to others. Once this petition is filed, then the courthouse takes that and sends out the police or the sheriff to pick the patient up and bring them into the hospital. The patient is brought into the hospital on this petition for commitment, and then in 3 days they are required to have a trial, and they are given an attorney, or they have their own attorney, but they actually have a trial where they bring the judge in, and the judge decides by testimony from the patient, any family members, and from the physician from the patient's physician, if he should commit the patient or let the patient go. And then that commitment lasts until the doctor has discharged the patient. Now, as I said before, just because you have a petition for commitment does not necessarily, and you're brought into the hospital, it does not mean that you're committed yet. Iowa statutes say that the patient has within 72 hours, which consists of working days, that they have to have a hearing and be determined if they are committed or not committed. And again, that's just to protect the patient's rights, that they are not in the hospital, for 4 or 5 weeks before they are actually determined if they're committed or not committed. Now, sometimes what we see happens is that we have a patient who comes into the hospital on a voluntary admission. They come into the hospital, but either during the course of their stay, we have been noticing that they are having some very serious psychiatric symptoms, but for whatever the reason, the patient demands to go, wants to leave the hospital. Now, if we believe, the nurses and the physician believe that that patient is a danger to themselves or a danger to somebody else, they can go ahead and petition for commitment and then hold that patient against their will in the hospital as long as they have filed for that petition for commitment. So we could have a patient who's demanding to leave and saying, I want to leave AMA, and may actually even, run out of the hospital and leave. If what we can do then is to have a physician and one other person file petition for commitment, and then we can hold the patient against their will. So that would be another example of how, or would be an example of how a voluntary admission can turn into a petition for commitment. All right, an emergency or 48-hour hold. This usually occurs after the business hours or on the weekend. And there may be a variety of examples of when we might get an emergency or 48-hour hold. One example might be a patient who comes into the emergency room for a cut on their arm, but as we are talking to them and assess them, we discover that maybe this was self-inflicted. The patient starts to tell us that they are feeling suicidal, they have no support systems at home, etc. And we may feel that we do not want to discharge them because we are fearful that they might do something when they are discharged here. If that is the case, then we would offer them a voluntary admission and say, we really would like you to come into the hospital and speak with the doctor, explore some of these issues a little bit more. The patient at that time would have the opportunity to say, yes, I will come into the hospital, or say, no, that I don't want to. Once they refuse coming into the hospital, then we have to make that decision. Do we truly believe that the patient is a danger to themselves or to somebody else? If we truly believe that, then we can initiate emergency or 48-hour hold. Now, the individual that does that can be the emergency physician or the nurse who is taking care of that. Many times, hospital emergency rooms will have a psychiatric nurse as a liaison or as a consultant that comes down to the emergency room and does specific assessments. At Genesis, they call it the PSA nurse, or the psychiatric screening assessment nurse. If the nurse who did that assessment talked with the ER physician and they decided, yes, that he is truly a danger to themselves, they would hold that patient against their will, call security to come down, or call, it might be the Davenport police, to hold the patient. The nurse would then call the magistrate on call, or call the the judge who is on call for that weekend or that after hours, and he or she would ask for a 48-hour hold to hold the patient. And the judge would give a verbal, yes, you can go ahead and hold them, or no, I don't believe you have sufficient evidence, but we would hold them for 48 hours. Sometimes what happens, if we tell the patient, we are going to have to get a 48-hour hold on you, we're going to have to call the judge, many times the patient will say, well, okay, I'll sign in. Or, they will come up to the hospital unit without a struggle or without any problems. Sometimes it is more of a struggle, and we have to put in other interventions, such as putting them in restraints or whatever, in order to do that. But once that 48 hours is put in place, within 48, with what is basically saying is that within 48 hours business days, so say they came in on a Saturday, the 48-hour hold wouldn't actually start until that Monday, but you would have 48 hours to go down to the courthouse and file your petition for commitment, and then that petition for commitment would start to take place, or would be in time frame would start with for a regular petition for commitment, where the hospital staff has 72 hours to have a hearing for the patient to actually determine if they need to be committed or not. And the last admission commitment issue is involuntary outpatient commitment. Involuntary outpatient commitment is when a patient is discharged, but they are on an outpatient commitment. Basically, this is they are discharged with certain conditions, and if they do not follow those conditions, they can be picked up by the sheriff or the police and brought back to the hospital for commitment to the hospital. basically, many of those conditions revolve around, for example, you can be an outpatient, involuntary commitment if you see your doctor every 2 weeks, and if you take your medication every day, or we'll talk about some of the different types of medication, or if you take your medication injection every 2 weeks. If you violate any of those conditions, then the physician can notify the sheriff and have you brought back into the hospital. Now, some of the basic principles with this admission and commitment is that a person, the only time they would be admitted against their will is if we felt they were a danger to themselves or to somebody else. And so there are state laws that protect those rights of the patient. And our last slide is client rights. Although I have a few listed down there for you, the ones that I want you to really focus on is the right to informed consent, the right to treatment, and I want you to read about those on your own, and I'm going to speak a little bit to the C, D, and E, which is, the first one is the right to refuse treatment. Again, this right to refuse treatment is based on the state's legal statutes. But this is basically saying is that a patient can refuse medications unless they are a danger to themselves or to somebody else, or else it is a psychiatric emergency. So many different states will have, variations on that. There are some state statutes which say that, once a patient is committed against their will, then you can give them medications or intramuscular medications. Other states will say, no, we can hold a patient against their will, but we have to have another trial or another trial to determine if we can give them medications against their will. Okay, again, the state is stepping in to to protect those rights of the patient. The next one, the right to treatment in the least restrictive environment. Again, we talked about that a little bit before. But again, trying to protect the patient's rights, that whether it's in an institution, a halfway house, supervised apartment livings, that we have to assess that patient and have them in the least restrictive environment. Okay, again, it might be a very long-term institution which would be the least restrictive for them because of the being a danger to themselves or to other people. It might be a halfway house. But we need to provide appropriate treatment with maximum freedom for that patient. Provide the least amount of limits necessary as we provide for their safety as well. And the last one that I'm going to highlight is the right to subject to unnecessary mechanical restraints. Again, this ties closely with the least restrictive environment, but they need to be in the least restrictive restraints. Nursing home has certain policies, hospitals have certain policies for this. That a patient should only be put in restraints only if they are a risk for harm to themselves or to others. We should never, and it's obvious, never have a patient in restraints for punishment or for staff convenience. That is very much against, state mental health code. Other things that go along with those mechanical restraints that the state mental health codes say is that they're, any type of restraints must be documented in a chart. We have to make sure that whenever we are using any type of restraints that we document what other interventions we used before we actually resorted to those restraints. And when we start talking about the violent patient later on in the semester, we will go through those different types of interventions that we must try before we put a person in restraints. That's not the first intervention that we go for at all. So those are a few of the highlights with the client's rights. The other ones, F through K, you can briefly look those over, but as I mentioned, the first A through E is what I'm going to be focusing on. And that concludes our Unit 2 lecture for Labor Day, and for those individuals who missed some of the other parts of the lecture.